This lesson will look at the basics of using POCUS to examine the shoulder. Shoulder pain is one of the most common MSK diagnoses encountered in the primary care office, and ultrasound can be a helpful tool for localizing injury, directing further imaging, or guiding diagnostic and therapeutic injections. As a preview, we'll start off by talking about the basic exam technique and normal anatomy of the shoulder girdle. Then we will highlight a few important pathologies that involve the shoulder which have characteristic findings on POCUS. My hope is that by the end of this lesson, you'll be able to identify the sonographic landmarks of these structures and interpret findings as normal or abnormal for each area you investigate. Let's start by reviewing the anatomy and basic technique for scanning the shoulder. The shoulder girdle is comprised of three bones: the humerus in the upper arm, clavicle in the upper thorax, and the scapula posteriorly. Several ligaments connect these bones to each other, with motion allowed through the complex network of muscles and their tendons that wrap around the humerus and allow the arm to have a singularly wide range of motion. However, this also predisposes the shoulder to injury, most commonly of the rotator cuff, which consists of the four tendons of the supraspinatus, infraspinatus, teres minor, and subscapularis muscles and their tendons. Motion through the joint's range of motion relies on the stability of these tendons and the smooth passage between bony prominences as aided by the cushion of the subacromial bursa, glenohumeral joint articular surfaces, and the bicipital groove. A comprehensive shoulder exam is typically conducted using a high-frequency linear probe and examines these six structures. There are a few ways to mentally organize the steps of this exam. For example, you can go based on physiologic function, examining groups of muscles or tendons that perform similar tasks, such as abduction or internal rotation, for example. Some people like to go based on anatomic classification, looking first at articular surfaces, then at the intracapsular tendons, and then the extrascapular structures. The way I organize my thoughts around this is based on the approach that's taken by my ultrasound probe. So, for example, the biceps tendon, subscapular, and supraspinatus muscles and tendons are all examined using an anterior approach. The infraspinatus and glenohumeral joint via a posterior approach, and the acromioclavicular joint via a superior approach. Whichever approach works best for you is fine, but this is the way that I organize my thoughts, and it helps me stay organized when doing an exam as well. Going down our six structures that we typically look at in the MSK shoulder exam, let's start off with our biceps tendon. Now remember that there's actually two heads of the biceps with two tendons, but the one that we generally look at is the long head of the biceps tendon, which courses up from the upper arm into the shoulder through the bicipital groove. So to image this, you want the patient to sit with their arm at their side, their elbow flexed to 90 degrees, and their hands supinated. You'll place the transducer horizontal to or parallel to the floor over the anterior shoulder, and your landmarks are going to be laterally the greater tuberosity, medially the lesser tuberosity, and then between them the bicipital groove through which the long head of the biceps tendon will run. A dynamic view will ask you to externally rotate the arm or flex the elbow to move this tendon and ensure that it's moving smoothly and without complication through that bicipital groove. And you can see biceps tendinosis or tendonitis, tendon subluxation, or rupture in the worst case scenario for the injuries of the biceps on this exam. The next view that we'll see from our anterior investigation of the shoulder is the subscapularis view. And what you'll have the patient do is maximally externally rotate the arm and supinate the hand, while keeping the probe over the anterior shoulder. However, you probably want to slide it or translate your probe just medially so that it's over the lesser tuberosity to see the tendon in the long axis. And then if you want to investigate in the short axis, you would just rotate your probe 90 degrees. What we see here is, and you'll notice I've kind of flipped this image up at the right to show you that how the structures would align, because these will be reversed when examining the opposite shoulder. But you'll see the subscapularis muscle, remember, attaches to the, or originates at the undersurface of the scapula and then wraps around the medial surface of this humerus, and then eventually becomes the subscapularis tendon through the rotator cuff attaching onto the tuberosities. And so having the patient go through an internal and external rotation will help you dynamically evaluate this and can bring out any subtle tears or areas of inflammation or edema. So a subscapularis tear can be visualized this way, as can tendinitis or tendinosis. And then this is also an important view for evaluating if there is biceps tendon subluxation. And the reason for that is because the subscapular tendon really helps to keep that biceps tendon in the bicipital groove by sort of overlying it. And we're not seeing a good view of that in this particular image, but if you have a subscapular tear, you have a higher risk of there being ability for that biceps tendon to then sublux out of the bicipital groove and cause issues. And so this is how you would evaluate the subscapularis. And then we're jumping on to our other anterior approach, or anterior view. So although this says view 5, I know it's only the third one we've seen. That's because I'm presenting these in the order that I typically ultrasound them. And so this is looking at our supraspinatus tendon. And for this, you want the patient to be seated with their arm in the crasp position, which is where the dorsum of their hand is sort of put into the small of their back and pressed against it. Or you could have them in the modified crasp position, which is basically asking them to put their hand in their back pocket with the dorsum of the hand, once again, being the side that is approximating their skin. And then you'll have the probe in the anterolateral shoulder, starting vertically over the greater tuberosity of the humerus, and then you'll slightly rotate towards the acromion or ear so that you can get that tendon in the long axis. So positioning is super important for this view because normally the supraspinatus lies underneath the acromion, and it's sort of hard to visualize it. And so having them in that crasp positioning really brings the tendon out from underneath the shoulder, or underneath the acromion, so that it can be viewed with ultrasound. Once again, you'll rotate 90 degrees for a transverse view. And your landmarks here are going to be the deltoid muscles superficially. And just deep to that, you should see an anechoic subacromial bursa. And this will be more pronounced if there's a large bursal process going on, like a bursitis or an effusion inside that bursa. But even without it, you should still be able to see a slight little thin hypoechoic or anechoic line. And then you'll see the flattened, what they call a footprint of the supraspinatus attachment. Which we can see here. My pointer. You see the humerus sort of flattens out, and it's almost like a giant little foot coming out and popping right onto the humerus as its attachment. Once again, you'll want the patient to go through internal and external rotation to dynamically visualize this tendon. And this is super important because the supraspinatus is the most commonly injured structure in the rotator cuff. And so it's definitely one that you'll want to investigate pretty thoroughly if the patient is having symptoms of rotator cuff pathology. Next, let's move on to our posterior views. So jumping back up to view 3 on our initial list of 6, this is our infraspinatus view. And in the infraspinatus view, what we want the patient to do is maximally internally rotate their arms. So you can ask them to place their hand on their contralateral shoulder. And then you'll place the probe horizontally over the posterior and lateral shoulder. And the landmarks that you're looking for here are the posterior edge of the greater tuberosity with the infraspinatus tendon in view. And then what you can do is translate your probe posteriorly, medially along the back of the shoulder there, and then eventually you'll be able to see the glenohumeral joint line. So you see the scapular spine down here, the humeral head with that greater tuberosity, and then the infraspinatus sort of right over that. And then this little V shape here is the glenoid fossa, and that's where we can investigate the glenohumeral joint in better clarity. And then, just as I mentioned on the previous slide, this is also how we evaluate the glenohumeral joint itself. Granted, we don't get a very big view of the glenohumeral joint just because it's a articular surface that's bounded on most sides by bony structures that prohibit us from utilizing ultrasound to investigate them. However, we can see the initial sort of V here, where the glenoid and the humeral head sort of come together, and this is also where we will see our labrum. This is also the most sensitive spot for us to identify shoulder effusions, and this view is 100% sensitive for effusions that are greater than 8 milliliters of the glenohumeral joint, as long as the patient is maximally externally rotated the arm. And then you can also identify labral tears, which might show that, medial motion or hypoechoic regions in the glenoid fossa, which could represent a disruption of this labrum. And then lastly, we'll move to our superior view, looking at the AC joint. The arm should be held in a neutral position or just sort of hanging off to the side, and that'll sort of open up this space, and the probe will be positioned over the acromion and clavicle, and it will be pretty easy to see the drop-offs where these bones end and the structure begins. You'll often see a little fibrous sort of balloon over the AC joint as the AC joint capsule with bursa. And this is also going to be the site that you'll want to do your injections in, which we'll go over in a little bit of a few minutes on some of our later slides. So now that we've gone over some of the normal appearance of the shoulder using ultrasound, let's look at what some pathology looks like, starting with the biceps tendon. The biceps muscle is heavily utilized for lifting, supinating, and other common tasks of daily life, and thus it's commonly injured. Low levels of injury, such as those caused by repetitive overuse strain, can cause micro tears in the tendon that are not always seen on imaging, but they still can create symptoms. If inflammation progresses, acute tendinitis or a chronic tendinosis can develop. And as you'll see as we go through these slides, the common finding for tendinitis includes a hypoechoic intratendon edema or defect, tendon thickening, especially if this is a more chronic process, and occasionally a fluid collection within the tendon sheath of tendons that have them. So in this image, we see the biceps tendon in the short axis in the bicipital groove. However, the uniform appearance of the tendon that we typically see is interrupted, and we've got this little hypoechoic defect here. We've got some other, it's just not quite as cohesive and similar texture that we normally see. And so these little disruptions of that normal architecture are concerning for inflammation and tendinitis. Here are some other examples of biceps tendinitis and tenosynovitis. And on the left, we see the tendon once again in the short axis, this time with a large peritendinous collection of fluid consistent with a tenosynovitis. So you can see this anechoic pocket that connects with that little space. In the middle picture, we see increased Doppler signal. So normally this should be a relatively low flow area. However, if we're seeing lots of little Doppler signals picked up on color flow, that could suggest acute inflammation and vascularization of the tendon as the body's trying to heal. And then lastly, in the image on the right, the biceps tendon is seen in the long axis with tendon thickening. So this is much thicker than what we would normally see for the tendon. And there's possibly a hypoechoic defect as well from here, maybe right over here. In this case, the findings are pretty chronic and suggested a long-standing biceps tendinosis. And so these kind of three things of seeing fluid collections, thickening, and hyperemia are going to be present in every single tendon and muscle that we look at that can get injured. And so it's an important kind of triad of findings that I want you to solidify as you investigate various structures. Acute injury or chronic inflammation can result in tear or complete rupture of the tendon. While typically presenting with an acute onset, sometimes patients will present with chronic weakness or instability or inability to move the arm through its normal range of motion. I find this to be especially true in my nursing home patients or other patients who have limited ability to communicate discomfort. Physical exam will often show weakness, and if the tendon is fully ruptured, the classic but rare finding of a Popeye sign with a mass at the side of the retracted tendon may be seen. And here we've got a view of that tendon, and we can see that there's a complete disconnect down here, and then the contracted tendon is seen as we translate the probe, representing a tear. Here are some other examples of tendon tears and ruptures of the biceps tendon. On the left, we're viewing the tendon in the long axis with the probe indicator towards the patient's head, and the torn edge of the tendon is seen in the near field on the right side of the image, right here. There's some surrounding anechoic fluid, which likely represents edema or a developing hemorrhage. In the middle image, we see the bony landmarks of the greater and lesser tubercles and the bicipital groove, but where there is an absence of the tendon in the bicipital groove. So we should normally see this tendon coursing through this structure, and instead we don't. Now, before we say that, we've talked about this multiple times, but remember that anisotropy can make things appear much darker than they are. So you have to be cautious. You really need to fan your probe to verify that this isn't just anisotropy before you say there's an absence of a tendon. And then lastly, the image on the right shows another short axis view of the biceps tendon, this time with an intratendinous tear. So here we see the tendon and it's sort of split with this hypoechoic structure kind of in the middle, as if we were staring down the barrel of the tendon. And all of these are different examples of tears and ruptures that you may encounter, but even though all of these are similar processes, the way that they presented on ultrasound were pretty different. And so you need to be familiar with what normal looks like, and if anything varies from normal, you should be suspicious for a pathology. The biceps tendon can also sublux out of the bicipital groove, which I mentioned previously, usually occurring in the context of a severe rotator cuff tear, particularly that of the subscapular tendon, which makes up part of the stabilizing mechanism for the anterior shoulder. So as the arm is rotated, the tendon can be seen sort of popping out of the groove, which we can see a still image of here on the screen. So here's that bicipital groove, and this tendon is sort of schlooping out over to the side here. Usually this pulls the tendon medially, and this can be subclassified further based on its location and the mechanism of injury for the involved structures, but I don't expect you to know those details. We'll save that for our sports medicine fellows. However, being able to recognize a subluxation or a dislocation may come in handy if you have a patient with joint instability and weakness. Next, let's turn our attention to the big hitter in terms of shoulder pathology and look at the rotator cuff. So rotator cuff pathology exists on a spectrum from mild cases of impingement syndrome to severe debilitating pain or even rupture of the rotator cuff tendons. Clinically, patients will often complain of anterolateral pain, but their symptoms can be posterior if the teres minor or the infraspinatus are involved, especially if the arm or pain is generated with external rotation. Reviewing our anatomy, the rotator cuff involves 4 muscles that originate on the scapula and insert on the glenohumeral joint capsule. The supraspinatus arises along the superior portion of the scapula, above the scapular spine, and courses superiorly under the acromion to attach on the greater tubercle. Due to its direct path between 2 bony surfaces and its importance to abduction and shoulder stabilization, this tendon is the most commonly injured structure of the rotator cuff. The infraspinatus and teres minor muscles originate on the inferior portion of the scapula, below the scapular spine, and insert on the greater tubercle, after wrapping around the posterior and lateral aspects of the humerus. These aid in external rotation of the arm. Lastly, the subscapularis originates on the underside of the scapula, wrapping medially and anteriorly around the humerus to attach on the lesser tubercle. Then, of course, there's a whole network of stabilizing ligaments and extracapular muscles that contribute to joint stability and function, but we won't focus on those in this lecture. Despite having lots of moving parts, the basis for ultrasound-supported diagnosis of a rotator cuff injury are identical to those of other tendons around the body, such as the biceps tendon that we looked at a few minutes ago. The challenge here is remembering how you visualize each tendon individually, which takes a mastery of the anatomy and diligent practice with your exam technique. We'll practice this together in POCUS Clinic, our MSK ultrasound workshops, and you'll practice this when you rotate with Dr. Neisler in MSK Clinic. Here are a few representative images of rotator cuff pathology, all of which involve the supraspinatus in this case. On the left, we see a tendon that has intratendinous hypoechoic interruptions and some irregular thickness, which represents tendinosis. The other 2 images show us partial tears of the supraspinatus tendon, represented by the hypoechoic defects being shown by the arrows that originate between otherwise brighter tendon edges. The middle picture shows a tear originating on the bursal side of the tendon. So up here, there's the subacromial bursa, and this is on the bursal side. And then the image on the right shows a tear originating on the articular side of the tendon. Next, let's take a limited look at the glenohumeral joint structures that we're able to see with ultrasound. Given the limited window into the glenohumeral joint due to bony prominences around the shoulder, ultrasound is mainly limited to identifying labral injuries, which are nonetheless an underdiagnosed cause of chronic shoulder pain, especially if a traumatic dislocation or a history of mechanical symptoms stands out in the patient's history. While ultrasound is not a perfect tool for investigating the labrum due to its poor sensitivity, hypoechoic defects that are seen in the labrum, especially those that widen when the arm is placed in gentle traction, do have a fair specificity for this diagnosis. Can't talk today. So here we see the labrum, which is a sort of triangular structure in the glenohumeral fossa, and then we see this hypoechoic structure kind of coursing through what normally should be a nice, solid labrum, and this can be a sign of a labral tear. Next, let's move to the AC joint. The AC joint can be evaluated using ultrasound to assess for subluxation and to guide our acromioclavicular joint injections. From a superior approach, the bony landmarks of the clavicle and acromion can be seen, and this distance between them can be measured using the probe in our measure function. So when the AC distance is greater than 3 millimeters different from the distance that you measure on the unaffected contralateral side, this is considered positive. So if the right shoulder is causing pain, you examine the left shoulder and get a value, and then measure the right shoulder, and that value that you measure on the right shoulder is more than 3 millimeters greater distance, that is positive. So it's not necessarily about the actual cutoffs of the numbers, it's more about comparing your affected side to your unaffected side. Acute separations may be accompanied by anechoic or hypoechoic effusions or hematomas, and chronic diseases, such as the one that we see in this image, can have hyperechoic findings and calcifications, which are seen here by the arrows. So you can see that this acromion and clavicle are pretty far apart. We'd need to make a measurement and compare that to the unaffected side to really quantify that. But there's also all of this junk in here that shouldn't be there, representing likely a calcific process. Finally, let's briefly turn our attention to go through the way that I approach shoulder injections under ultrasound guidance. So first, let's talk about our glenohumeral joint aspiration and injection. The indications for this are generally going to be osteoarthritis or adhesive capsulitis. And the approach I use when using a ultrasound-guided approach for these is by entering the skin posterior laterally in an in-plane approach, meaning I'm watching my needle the entire time in plane with the ultrasound while I approach the glenoid fossa. And the target is the glenoid fossa right at the junction of the humeral head and the glenoid. And so dynamically what this looks like is the needle will come in from the posterior side, and I'm aiming it towards the glenoid fossa as I then inject or aspirate. For AC joints, very similar, pretty easy exam to do even without ultrasound guidance. But if you are using ultrasound guidance, because this is such a superficial joint, I often utilize a out-of-plane approach for this joint. And so once again, your positioning is going to be having the patient sitting with their arm hanging at the side, your probe superiorly over the AC joint, and then out of joint coming from the front of the body towards the middle of the probe as it's centered over the AC joint. The needle is inserted out of plane, and I watch it and slowly advance it into the AC joint itself before I aspirate or inject. And then lastly, the subacromial aspiration or injection. This is the one that I do most commonly because rotator cuff pathology is just so prevalent in our clinic system and in patients in general. And for this one, I usually use a lateral in-plane approach. So I place the probe over the acromion and try to identify the kind of edge of the acromion as seen here with the shadowing underneath it. Here's our supraspinatus tendon that's coming out from underneath it. And the approach that I'm trying to take is into this bursa, which lies right between these two structures. And so let's take a still image here and then introduce my needle, which comes in from the lateral portion of the shoulder right into that bursa just above the supraspinatus tendon. And then a little bonus video I have here for you is a dynamic view of a humerus being reduced back into the shoulder joint after a shoulder dislocation. So we see a traumatic dislocation here. There's some blood inside the space, and then the ultrasound shows us reducing the shoulder back up into spot. So this is not something that I routinely do in practice. I've reduced a couple of shoulder dislocations in the ER and one in clinic, and I did not utilize ultrasound for them. And I don't really know how or why an ultrasound was being placed on this patient, but it was a cool video, so I thought I'd share it with you guys and show you that there's other things that you can see in MSK ultrasounds that we aren't even going to touch here in our lecture. A few pearls of evidence that I want you to know about is that detection of effusion for the shoulder approaches 100% sensitivity. So if you're concerned that there could be a shoulder effusion, ultrasound is your investigation of choice for that. POCUS improves injection accuracy from 89% compared to a 61% using landmark approach. So it really should be the modality of choice, especially if you're not really comfortable with your landmark guided injections. And ultrasound guided injections have been shown to have a superior efficacy for pain relief when done using ultrasound as opposed to landmark. And the injection itself is reported by patients to be less painful when using ultrasound. So those are some patient-oriented evidence pearls that support the use of ultrasound when investigating and therapeutically approaching shoulder pain. So in this lecture, we talked about exam technique and normal shoulder anatomy. We went through some of the different tendons and structures in the shoulder, including the biceps tendon, the rotator cuff, and the glenohumeral and AC joint, and how different pathologies appear on each of those when investigated using point-of-care ultrasound, and then briefly showed you the approach that I like to use for my ultrasound-guided injections of the shoulder.